Welcome back to Clinicians Brief, the podcast, the conversations behind the content. I'm the host, Dr. Alyssa Watson, and today we're going to be discussing 5 potential complications associated with indwelling urinary catheters. Joining me is Dr. Rebecca Walton. She's a criticalist at VCA West Los Angeles in LA, California, but she's also a clinical associate professor at Iowa State University, which is my alma mater. Dr. Walton is here to walk us through each of the 5 complications that she highlighted in her May 2023 article, and we're going to explore the underlying causes, potential warning signs, and strategies for effective management in each of these scenarios. So we're so glad that you could be here with us today. How are you doing, Dr. Walton?
I'm doing well. Thank you for having me.
So before we jump into this episode, I would love it. I was really intrigued with how your schedule worked. And so I would love it if you would let our audience know a little bit about your background, how you ended up working on the middle of the country as well as the West Coast at the same time.
Good questions. Yeah, it's not a normal arrangement, but following my residency, I took a position at Iowa State and have been there for about 7 years. I love teaching in academia. I'd never been to the Midwest. I'm from Southern California, but loved Iowa. And then decided to get closer to family, closer to home. So took this position at VCA West LA, but couldn't fully leave academia. So for a while, I was going back every month to do some clinical weeks and spend some time in Ames, which has been fun. And then this year I'll go a little bit less, but continue projects and research and stuff with the team at Iowa. So best of both worlds.
Yeah, absolutely. You're kind of the opposite of me. So born and raised Cedar Rapids, went to Iowa State to get my DVM, and now I'm on the West Coast in Las Vegas, so fairly close to LA. We run to the beach as frequently as we can. So
need a break from the heat.
Yeah. It hasn't been too bad yet. We're coming in on summer, so triple digits are coming, but so let's talk a little bit about urinary catheters. So I am a general practitioner. Definitely the thing that I am doing when I'm placing indwelling urinary catheters is almost always for blocked tomcats. But what are some other common clinical situations in which these catheters might be necessary?
Yeah, I totally agree. I think that's the majority of our cases, those blocked male cats. But diagnostically can be helpful as well. Some cases when we're worried about transitional cell carcinoma or worried about doing a cystocentesis, that could be something even for temporary. Or to me, the other big use is managing patients. And so particularly down dogs, whether they're post-op from a hemilaminectomy or just really critically ill and keeping them clean is a priority. I think they can be very, very helpful. And then diagnostically, we see a lot of acute kidney injuries, whether it's toxins or infectious diseases. And so indwelling catheters can be really helpful to measure urinary output and get a better idea of our patient's fluid balance. Sometimes it's more challenging in females. We might be more likely to place it in a male. But in general, I think it can be helpful. Dogs and cats, both, like you said, most common in our blocked cats. But I would say something that we can use fairly frequently that helps keep our patients clean and cared for, but also helps us manage them as well.
Yeah, I think another big thing that I am putting them in for is cystotomy surgeries. Like you said, not necessarily going to be in long, but at least a little while.
Yeah.
I know I had a case where I had a female dog that I did not place a catheter prior to her cystotomy, and then took that post-op X-ray, and there was a big stone right in the urethra. And I was like, no.
Yes.
So I always do that now.
Yeah, I totally understand.
One of the things that you mentioned in the article was that the incidence of complications with indwelling urinary catheters can be as high as 50%. And I was surprised by that. I thought that was really high. So does that include things like minor complications as well as severe complications?
Yeah, good question. It's an overall. So by far and away, the majority of those are going to be the irritation or the hematuria or the subclinical bacteria that really don't affect our patient management or care. I think when we investigate further, we see a high incidence. Luckily, the more concerning complications, urethral trauma, stricture, knotting, the feared knotted catheter, are much less common. But nothing that I can find literature, really breaks down each incident. So it does sound scary and does sound high, but the majority are going to be those minor things that really don't affect our patient management.
That's good to hear at least.
Yeah.
So,
We don't need
are
to be
there,
scared.
yeah, the nodding. We will talk about nodding later because that is
Yes,
something that keeps me up at night. I am so fearful of
totally
that, but we'll
understand.
talk about it later. Um,
For sure.
are there any specific patient populations that are more prone to experiencing complications?
Yeah, it's a great question. Some studies say that females aren't more predisposed, but in general, that's always a bigger concern for me. Part of that is logistics. Some of these patients are really sick and having diarrhea, which always worries me in a female in terms of keeping them clean, making sure that we're managing that catheter. So, from what I can find, a lot of studies didn't say that sex was a risk factor, but I always worry more in females. And if there's any diarrhea or, that is usually a reason that I not necessarily hesitate, but I pause to make sure, do I really need this urinary catheter? Because I worry that the risks do go up a little bit. But in general, I think being aware of them, the majority of our cases can do very well with urethral catheterizations. But again, just being aware of potential complications.
Sure, that totally makes sense with the anatomy, as to
Yeah,
why that would be more of a concern. So,
exactly.
um, there's so many materials and everything out there. And you do a
Yes.
great job of running through a lot of these in the article, but could you just give us kind of a
Yeah.
rundown on what we should be keeping in mind when our goal is to minimize inflammation, minimize trauma, how should our catheter selection be based on those criteria?
Yeah, that's a great question. And I think part of the struggle is a lot of it is there's some personal preference.
Mhm.
To me, the type of catheters that worry me the most, I don't want to say scare, but I'm very hyper aware of are the Tomcat catheters, the polyurethane, because they are so stiff. And stiff can be helpful in terms of more ease of placement, but those are more likely to cause damage if they're left in place. So I tend to avoid those. I know people use them and they go very, very well, but I tend to avoid those. For other like blocked cats, I know people prefer the red rubber catheters. It's kind of the balance between being stiff but soft enough to be left in place. I also like slippery Sam catheters too. I also find that they're stiff enough but less irritating and a little easier to secure in place, I find, than red rubbers. So I think all of those are fair. I tend to prefer the slippery Sam. And then for longer term dogs, I think the Foley catheters are really the best just in terms of having the balloon in place and less
Sure.
movement and irritation to the urethra. So any dog that can fit the from what I am aware of, they don't have Foleys smaller than a 5 French. So if I have a dog that can fit a 5 French, then I'll put a Foley, but smaller tiny dogs or cats, usually it would be a slippery Sam or a red rubber.
Okay. So oftentimes we're going to need sedation or even general anesthesia in order to
Yeah.
facilitate
Yeah.
placing these catheters. Do you have just some protocols that are kind of your go-to for dogs and cats?
Yeah, great question. Yeah, sedation can be really challenging, blocked cats, female dogs. My combo is always an opioid. I tend to like fentanyl just because we can give a bolus and keep them on it depending on why they're there, if they're going to surgery or staying in hospital, but methadone or
Mhm.
hydromorphone, any of those. In cats, I'll use buprenorphine as well, but an opioid. And then I always use a benzodiazepine just for relaxation, but potentially helping relax the urethral sphincter as well. I tend to like diazepam a little bit better than midazolam. I feel like it sedates our patients a little bit better, but either one. And then I'll usually, if I need more, top them off with some ketamine. So usually an opioid, a benzo, and ketamine. And then those really tough ones, I agree, then I fully anesthetize them. But
Mhm.
in that case, at least it's a good pre-med combo. So I'll still give them that and then induce the anesthesia if needed.
Yep. Yeah, I've been seeing so many more people using ketamine. There's a lot of talk with long-term sub-Q ketamine for pain, for chronic
Yeah.
pain. But I talked with another a doctor that was using it as like a bolus during surgery for, acute spikes in pain. So there's a lot of really good uses out there. And I think
Yeah.
that, that's something that it's good to revisit, some of these medications that we've kind of I feel like we've
Yeah.
moved away from a
I
little bit
totally
over
agree.
time in my 20 years of practice, but
Yeah.
and now we're renewing interest in these medications. So that's pretty cool.
Yeah.
Yeah.
I agree. I didn't use it a lot to
Yeah.
start, but I use it more and more. I like it a
Yeah.
lot.
Promazine is another one. I've heard that's
Yeah.
another one that can help relax the urethral sphincter
Yeah.
too. Yeah. So
Yeah.
very interesting.
I use a lot of ACE, even in like our hospitalized cats with
Mhm.
urethral obstruction and catheters. So I agree. I like ACE a lot too.
You had said in the article that, we really want to minimize these repeated attempts at catheterization, as well as minimizing movement, because that's what's going to help us decrease inflammation and this potential for those worse complications like you were talking about, like stricture. There's really beautiful, I encourage, everyone to go look at the article because there's really beautiful kind of step-by-step and pictures and a detailed description on how to properly secure these catheters in a cat. How do you modify that for a male dog? I had a male dog that I had to put a urinary catheter in, and I was like, where do I sew
It's like
this?
suture. Yeah.
Right.
Yeah, you're totally right. I actually do very similar to the male cat. I still put the tape along the catheter that I think helps prevent movement, keeps it a little bit cleaner as well. And then similar to the cat picture, I still do 2 sutures, but to their prepuce. And so it's still pretty similar. I would for all I think. I was trying to think of female cats, which is our least common population. I think
Sure.
that we need them in. But I do the same thing for female dogs and cats, tape, and then just suture it right in that area.
And then kind of going back to what you were talking about earlier with all the different types of catheters, certainly like you said, a lot of people like those more rigid catheters to relieve an obstruction. And I know a lot of clinicians will like relieve the obstruction with a more rigid catheter, but then replace it, with something like, a slippery Sam or something to leave it, longer term.
Yeah,
So that seems like kind of a balancing act between like recatheterizing or leaving
exactly.
in something that potentially is stiffer. Do you have opinions on that?
Yeah, that's a great question. I know so many people do it differently and not right or wrong. I think that's also why I like the slippery stand because I can usually unblock them with it while flushing and then just leave it in, and then I don't have to worry about repeated catheterizations. So I agree. I don't use the rigid Tomcat. Hopefully, it's just a one-time thing and then suture it in place. I know people absolutely do it the other way. And I
Mm-hmm.
think I just always worry about force and, people have been doing it a long time and do a great job with it and are just cognizant of technique. But that's why I like the slippery Sam too, because I don't have to do it more than once.
Yep. So one of the complications, is urethral stricture. But I've always kind of wondered, like if a urethral stricture were to occur, what are the typical clinical signs of that? Like, how would I be aware that that's happened?
I think that's such a great question. And I think that's something that I think about a lot because a lot of these, particularly, blocked male cats, we know there's a high incidence of recurrence, but I do wonder, what proportion of those could be strictures and we just don't diagnose it or don't know. And a lot of these, depending on, how many offenses, a lot of these cats get a PU. And I do
Mhm.
wonder maybe there was a stricture causing that reobstruction. So I agree. I think it's so hard to diagnose because usually they're just going to have the same signs that they started with. And so we might be blaming it on, their cystitis or something like that. But I do wonder if there's a higher incidence of strictures than we're even aware of.
And when we have that complication, are there any non-surgical approaches, or do you just need to go to surgical intervention like a PU when we have a stricture?
That's a great question. I think at least in cats, I think their urethra is so narrow. So the only way I've managed them is to go for a PU. Pros and cons of that. And I know people have opinions on that for sure. But that's the only way I've seen it. I think potentially in a larger dog, depending on the stricture, could we stent the urethra or do something like that interventionally with our internal medicine colleagues? I think there are probably a little bit more options for dogs and a larger urethra, but particularly for cats, I've only treated them surgically.
Life in the clinic is busy enough without wasting time looking for things. The revolutionary new Plums Pro combines our trusted, time-tested drug information with everything you need to get through your busiest days. Subscribe for anytime access to concise, practical monographs covering diagnosis and treatment topics, algorithms to guide your case management, and a library of more than 750 shareable pet owner guides. Plums Pro is fast, easy to use, and always right at your fingertips. We can't guarantee you'll always be able to find a working otoscope head, but we'll take care of almost everything else. Find the clinical support you need the first time, every time at plums.com. So going back to when we are trying to relieve that obstruction, you talk in the article, you're a big proponent for hydropulsion and as a way to relieve that obstruction, as opposed to, trying to force your catheter in there so that, we don't cause trauma. I've also heard about doing like cystocentesis in order to relieve the back pressure. There's a lot of back pressure in these blocked cats or dogs. If a dog is blocked as well, the bladder's enlarged and that back pressure can oftentimes, make it more difficult to pass your catheter and relieve that obstruction. So do you generally recommend that technique, or do you have opinions on it?
I do. I think it's such a great question. And I did my internship at University of Minnesota, and every single cat got decompressive cystocentesis and dogs. And then when I did my residency at NC State, I think they looked at me like I was crazy at first. They just do it very differently. And so, looking at the literature, the good news is it's not associated with higher complication rates, not increased incidence of uroabdomen or anything like that. I think some of the studies also say it doesn't necessarily help, but how I've kind of melded that, and what I do is any patient that's unstable that I'm worried about, I always do a decompressive cystocentesis. I think it just helps stabilize them. We can treat them in other ways and give them relief. I'm sure it's incredibly uncomfortable. Or depending on your schedule, if you have a blocked cat, for example, come in and you have a morning full of appointments and the cat's otherwise stable and it might be a couple hours before you can place that urinary catheter, then I do it then as well. So I really like doing decompressive cystos if it's a case that they're otherwise pretty comfortable, stable, and I can do it right away. I don't always do it, but any patient that I'm worried about, I do a decompressive cysto.
Yeah. They used to really scare me, but now I do them routinely as well. Luckily, I have not had one that, has had a bladder rupture or something like that, but we know that that's possible. So that kind of leads right into our next question, which is, what are the signs and symptoms that indicate, severe trauma or rupture of the bladder or rupture of the urethra?
Yeah, it's a great question. And sometimes it happens so rapidly. I've definitely seen dogs I had one recently that came in urethral obstruction, vomited once. We could palpate a bladder when he got there, vomited once, and then all of a sudden we're like, oh no. And he was very obvious. He was very tachycardic, much more painful all of a sudden, acutely weak. And so sometimes they'll give us a good clinical indication. The other times that my index of suspicion has increased and I've been more worried is, well, I'll be passing, in a blocked cat, passing a urinary catheter or even a dog, and it feels like it goes in, but I'm not getting any urine. That always worries me. And so to me, the nice thing is point of care ultrasound is I think more readily available in most clinics. And so if I'm worried, I'll just pop a probe and look for any effusion, because sometimes we'll catch it really early just because something feels wrong or we're not getting any urine when we pass that urinary catheter. And then knowing right away, we can intervene quicker and hopefully avoid some of the chemical peritonitis. But I've also seen dogs that tell me right away with clinical signs if there's any complication. And then I usually get either x-rays or just a brief point of care scan once the catheter is in to confirm its place, because hopefully if I'm not in the right place, then I will know sooner rather than later.
And once you find out, once you've scanned and there's free fluid in the abdomen, or you can actually, possibly see that your catheter is outside of the urethra, what immediate steps do we need to be taking to stabilize that patient?
Great question. And the biggest thing is pain. Chemical peritonitis is uncomfortable. Usually they have pain meds on board, but being really aggressive with pain management. The other thing is trying to drain that abdominal effusion. So if there's a large amount, getting as much out as we can. And so that could either be a therapeutic abdominocentesis, or I've put in an abdominal drain to keep them empty. And then the combination of draining the abdomen and getting a urinary catheter in place just to make sure the bladder stays empty, that can be harder to do. We say get a urinary catheter in place, but obviously that's what we're trying to do. So I've definitely had some that, we try and we just had to go straight to surgery because of that. I think the debate I was thinking about too is just to take them to surgery versus not. And, I think one argument is, well, if it's a tiny hole, maybe it'll heal and we can medically manage them with a urinary catheter and a drain. I think I tend to be more aggressive with recommending surgery. That dog I just mentioned, he had stones and he had a big bladder and, rupture. He vomited and we watched it happen in hospital. And we took him to surgery and his bladder was in half. And so you would think, in what world, he did great, but in what world, did that cause that much? And you don't really know how big the defect is. So I tend to err on the side of going to surgery, once we get them stabilized, fluids, pain meds, draining what's in their abdomen. But I know some, I'm sure, would heal with time, and, the mucosa heals very well. So could be medically managed. I just worry about, managing them for a couple of days and then still needing surgery.
So let's talk a little bit about some of these less life-threatening complications.
The less scary ones.
Yeah, the less scary ones. So hematuria is something that's very, very common with indwelling catheters. How can I, as a clinician, differentiate between hematuria that's just associated with, the catheter being in place, like catheter-related irritation, versus something like a urinary tract infection that I need to be treating, or sterile cystitis?
Such a good question. I think it's very, very hard. Some of the cases I feel like the urine will look very clear and then kind of we'll see an acute change. And sometimes that'll be the cat that's, more active or the dog that's moving around. And so we worry more about tugging on the catheter or causing irritation. But I absolutely agree. It can be really, really hard to differentiate. And I think we know, cats sometimes when block and their urine looks red. And so how are we going to differentiate if it's their cystitis versus, something else? And I would say that's probably one of the biggest challenges to differentiate, particularly in again, in cats, when we're trying to use that as criteria to pull the catheter, but
Right.
then I always have the debate is it because of the catheter? Do I pull it? Do I not pull it? And so it can be very, very challenging. If I'm really having a hard time, we can spin down and look at a urine sample too. Are we seeing more white blood cells or bacteria or anything that might sway us one way or another? But usually I'll use their clinical signs. Are they eating? How are their values? And kind of go from there, because those, I agree, are really challenging. And I'm sure there's a lot of cases that we say, oh, it's probably the catheter, we pull it, but it wasn't, or vice versa. So those are really challenging.
Yeah, absolutely. So, kind of reminds me of same thing with drains too. Like, is it still draining because the drain is
Yeah.
in, or is it still draining
Which
because the
one?
drain needs to be in?
I know. The age old, how much? It's normal. I know. It's the
Right.
same.
So, um, so say we were trying to figure this out, and we spin down and we see some bacteriuria. That's the next kind of thing that we need to differentiate is this, because there's a lot, not just with indwelling urinary catheters, but just subclinical bacteriuria. There's lots of
Yeah.
new information, whether or not we should be treating this. I've seen some studies recently in diabetic animals about,
Yeah.
should we be really doing all of these, urine cultures? What are we doing here? And is it really benefiting our patients? So you said we probably don't need to be treating subclinical cases. So can you explain the rationale behind that?
Yeah, I think it's similar, like you said, are we over prescribing antibiotics? Or are we prescribing antibiotics in patients that don't need them? And in a lot of these cases, hopefully not the black cat, but some of these patients that we have them in these catheters in place because they're critically ill, antibiotic resistance and overuse, and the more we use the antibiotics, the more likelihood they'll get an infection. So it's kind of a vicious cycle for sure. And so I guess where I would use that is to say I would be more inclined to remove it if I thought appropriate. So if I had a case that I was seeing subclinical bacteria, I would want to get the urinary catheter out sooner rather than later, again, depending on why it was in and how they're doing. But I agree, waiting for signs to say, do I think it's affecting you? Are you febrile? What's your CBC looking like? Which again can be challenging because these patients are usually sick from lots and lots of reasons. But I think, one general struggle with veterinary medicine is antibiotics and how long. In people, they'll treat you for a UTI for 3 days. And I think we're getting a lot better about duration of antibiotics. But I think we use them a lot, and probably in patients that would clear it on their own, that probably don't need that exposure.
Yeah. Yep. Definitely another thing that I'm seeing kind of a move towards that, higher dose but shorter duration treatment for different urinary tract infections. So let's talk a little bit about collection systems. So I think a lot of people realize that a closed collection system is the way to go, right?
Yeah, yeah.
So how what are the basic pros for that in order to minimize risk for infection?
Yeah, basic pros is it just always is something that we can empty. We can collect urine. We can empty the bag, and everything just stays sterile or without introducing anything. I think a lot of places, and resource wise, it totally makes sense. Those can be expensive to have those systems. So I totally understand a lot of people, which is creative and totally makes sense, can hook it up to an old fluid bag for sure. And so anything that has a system in place, I've seen catheters that are just open, and that definitely worries me in terms of risk of ascending infection. So any sort of system I think is ideal. The urinary bags are just designed in a way that we can empty them and we're not unhooking and touching them as frequently, which I think is
Mm-hmm.
nice. But again, they can be expensive. So I totally understand the resource reason for keeping it hooked up to an old fluid bag. And so if that's the case, totally understandable. I think probably the biggest thing that sometimes we forget about is, our impact, washing our hands,
Sure.
wearing gloves when we handle
Mm-hmm.
it. Patients and catheters, I think, if you're in a rush and you're doing many things, we're all guilty of it for sure. But in those cases, doing our best to cleanly handle it, I think is helpful as well.
Yeah, absolutely. Definitely something that unfortunately probably in veterinary medicine does get missed a little bit. We're
Yeah,
not as worried about,
yeah,
contagious disease,
exactly.
from like they are in a human hospital. But like you
Yeah,
said, yeah, if you're switching out that bag, probably a good idea to throw some gloves on.
yeah, exactly, exactly.
So, um, I are there any, this is a weird question, but like,
No,
are
I
there
love it.
any situations in which an open collection system would be appropriate?
Um, the time that I've seen kind of open systems that we're doing what we can is some temporary stents. I know Dr. Lulich actually taught me from University of Minnesota, but patients that had TCC that might not go for the whole urethral
Mm-hmm.
stent, you
Mm-hmm.
can temporarily place a red rubber. They're incontinent, they're at risk for UTI, but they're
Sure.
obstructed from their TCC. So to give them some quality at home, I've seen that. And the one case I can remember managing as an intern, I think she got a month at home, and again, she was incontinent, but she felt really good. And so
Yeah.
people are and obviously there's a risk of infection, but good quality of life at home for a temporary benefit, I think makes sense.
Yeah, absolutely. I would not have thought of that as, kind of like a palliative
Yeah, exactly.
therapy. No, that's
Yeah.
really that's wonderful. So we've come to the last
Yeah.
the
The
last
dreaded,
complication, the dreaded
the dreaded
because I
kink.
have seen the dreaded
I
kink,
know,
and
too.
it's actually nodding. I have seen,
Yeah.
certainly like on different Facebook groups that I'm a part of, and people put out an SOS, my
Yeah.
catheter, knotted, and not even indwelling catheters. Oftentimes this is like they placed a catheter in order to get, a urine sample for
Urine
something,
sample.
and then they can't get it out. So, what should you do?
Great question. I have also seen and fear this complication. One thing I try to remember to do, and I'll be honest, sometimes you forget, is just measuring about how far we want the catheter in. And I think, like you said, that could be something with a temporary red rubber, but I'm definitely guilty of doing it with a Foley catheter. Some of those Foleys are so long, and I think it's very easy to just feed it in, all the way, blow up the balloon and pull it out. I'm
Mm-hmm.
definitely guilty of doing that, and you forget to measure. So I try to remember, or just even eyeball, when do I think I'm going to be in the bladder, so we can try and aspirate so I'm not feeding this catheter that's going to kink or not, I think is helpful. I've definitely ended up in that scenario too. I've tried to like flush the catheter to see. I've also had to get our internal medicine team in to scope and untie it. And then surgery. I can't think of a case that I've had to send to surgery, but I would imagine it's a total possibility.
Mm-hmm. Mm-hmm. I've also heard of trying to like pass, a stylet or another catheter down the center in order to unkink it.
Yeah,
Yeah.
I totally agree. Trying to feed the silent, I think sometimes
Mm-hmm.
same problem, it doesn't feed, but it totally makes sense. I think getting creative in these situations because our alternatives are challenging in terms of scope or
Mm-hmm.
surgery. So I totally agree. Flushing, trying to feed a stylet, seeing if we can unkink it, but I've
Sed-
definitely seen them have to go.
sedation.
Yeah, yeah, that's a great point.
So
Yeah, yeah,
another
totally
time
agree.
to really like sedate them, get them
Open,
relaxed.
yeah.
Yeah, open up that urethra as much as we
Yeah,
can.
totally agree.
Yeah.
Yeah, that's a
So,
great point. Even
yeah.
anesthesia, yeah, that's a great point.
But those are good tips because I hadn't really, I'm like you, oftentimes I'll be in a hurry or something and I'm like, okay, and you just keep going, or
You
I'm
do, yeah.
distracted talking, to somebody
Mhm.
else and giving orders for something, in the treatment room. And so making
Totally.
sure, just like anything else we're placing, an ET tube or,
Yeah.
a feeding tube where we're like,
Yeah.
okay, it should probably only be going in thus far,
Yeah.
and not to, because certainly you can see how if you feed it in too far, that's when we're worried about it doubling back on itself and potentially, getting into one of those knots or kinks or something like that.
Exactly.
So
And some of those Foleys are crazy long.
yeah, they are.
So
So, Well, that was all of our questions about urinary catheters, and those are some great tips. So I know that I'm going to take away some good things. But before I let you go, before I let you go, there's one last thing that we like to do. We like to play a little game with our guests. It's just a series of fun, like, would you rather questions. There's no right or wrong answer. Oh, good. Excellent. Well, then we will start right now.
Yeah.
Okay. So would you rather learn a new skill every single year, or would you rather hone one skill and become the best in the world at that one thing?
I'd have to go every single year because I always say criticalists are jack of all trades, master of none, in a positive way. So to fit with my theme, I would go new skill every year.
Yeah, I like to learn new things too. Okay, so this is one. So with our theme of urinary catheters, would you rather retrieve a urinary catheter that is fractured off in the urethra or an ET tube that was chewed off and aspirated?
That's a really good question. I deeply love respiratory emergencies, so I'd be up for the challenge for ET tube.
All right, excellent. Would you rather work a relief shift at a busy ER without an oxygen cage or without any fluid pumps?
I can get creative with oxygen, so I would say without an oxygen cage because I don't know a criticalist that can survive without fluid pumps.
Okay. You're not going to sit and set your little drips? Yeah, your drip rate?
Drip rate. I could get creative either way, but I think I'd go with that oxygen.
My first practice was pretty rural and we had one fluid pump. And so if it was being used, we were calculating drip rates.
Yes, I know. I should be good at that from doing it for blood transfusions, but math's hard.
Okay, this one, I think it might be hard for you.
Okay.
Would you rather continue teaching but no longer practice, or continue practicing but no longer teach?
Oh, that is so hard. I think I would continue teaching. That is very hard. I love practice. But I remember someone asked me, what's your impact on veterinary medicine? Are you going to do research? Like, what are you going to do? I like research, but definitely not my thing. And I think my biggest impact is teaching, and then that goes everywhere and saves even more pets than I could save. So I think I would continue teaching.
All right. Oh, that's such a good answer. All right, last question. Most important question, last question. Would you rather go to the premiere of a new star on the Hollywood Walk of Fame, or would you rather go to the reveal of the annual butter sculpture at the Iowa State Fair?
Butter sculpture, hands down. Butter sculpture. Cows. Sesame Street, I think, when you're butter sculpture.
I love the butter sculpture. We are now best friends.
I love that fair so much. The benefits of Iowa. I love it.
Dr. Walton, this has been fantastic. Thank you so much for sharing all these tips with our audience today.
Thank you for having me. It was super fun.
Thank you for listening to today's episode of Clinicians Brief, the podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version that's available on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts. Or drop us a line at podcasts@briefmedia.com. Clinicians Brief the Podcast is a VetMedics production. Produced by Alexis Ussery and hosted by me, Dr. Alyssa Watson.